Okay, hello everyone. Once again, welcome to the first affiliated hospital of Harbin Medical University. The patient for today is a 56 years old male. And also we can see that there are several risk factors of this patient. He accepted PCI 10 years ago due to the old myocardial infarction. And he is a relatively very heavy smoker and he has a history of smoking for 20 years. And recently, the patient complained about the chest pain during the previous 4 months. And we can see that this is the chest pain of stable angina pectoris. And the echo indicated that there is no left ventricular wall motion abnormalities with the EF value of 70%. So this is the ECG for this patient. So we can see that this is standard rhythm and also lead inferior with the lead 2-3 and AVF. We can see the QS form, which indicated the inferior wall damage. However, we need to check the old myocardial infarction, which is the location. This is laboratory data. We can see the troponin I is within the normal range. So our diagnosis for this patient is a stable angina pectoris, old myocardial infarction, and hypertension. So next, Professor Gong is going to introduce the angiography for today.
You can see in the stent in the LED proximal to middle segment, there is also a stent in the first diagonal proximal segment. But in the ostium of the first diagonal, there is significant stenosis. You can see the stenosis is very severe and focal. The first diagonal is very long. For this reason, we should perform functional assessment by FFR to evaluate the significance of the diagnosis and decide to if we should perform a PCI for this reason. So the collateral from left coronary to RCA, and the RCA vessel is very big, and we can see the collateral from circumflex and from LED to the RCA. For RCA coronary angiography, you can see the proximal chronic total occlusion.
So thanks for the introduction of Professor Gong, and we see that after the integrated approach using a fielder family wire that we successfully, penetrated through the fibrous cap, and after switching to the workhorse wire, and we use a 2.0 balloon to make some pre-dilation, to make slightly plaque modification to try to help the IVS catheter to pass through, and then we make this pullback. It's a relatively long pullback, so we focus on the proximal occluded segment. So at the beginning of this pullback, we can see that it's almost in a 3.5 vessel with almost no plaque as the proximal part distal to the occluded segment. And also as the IVS catheter is pulling back, we can see some eccentric, fibrotic with some a little bit, maybe I think that's a calcified lesion within the plaque. However, it's not so, heavy because there is not a very heavy attenuated plaque. We can see some plaque control dissection and also very heavy plaque burden with eccentric, and also maybe due to the 2.0 balloon dilation caused some intima dissection. And this is the proximal segment. From the bilateral angiography, we notice that the occluded segment is not so long. So according to the IVS, it's maybe 28 to 30 something from the length. And something we need to notice is that we can see here, which is the most severe part within the occluded segment. The plaque burden is very high, and also it seems to be very heavy fibrotic and calcified lesion. So maybe some very wild modification of the plaque is required. Maybe some scoring balloon or cutting balloon is required.
Based on the result of the IVS, and we know the heavy plaque burden, then we choose a cutting balloon
Mm-hmm.
3.0 cutting balloon
Mm-hmm.
to perform pre-treatment
Mm-hmm.
again for the lesion preparation.
Okay.
Now we have finished the cutting balloon modification.
So I think that this is a very good choice for using the cutting balloon for this plaque modification because compared to the other scoring balloons, cutting balloon is highly likely to cause less trauma to the vessel wall because we know that the microblade, the working height is relatively low, so it's less likely compared to the NSE or the other balloons to cause very severe intima dissections. And here we can see as they start out putting back, once again we confirm it's over 3.5 vessel. It's nearly 3.8 maybe by the visual estimation. Again, after the cutting balloon modification, we can see that the plaque, it seems to be that the instant lumen gain is relatively good. However, one thing that I worry about is it's extremely eccentric plaque, which is not so friendly for the stent expansion because under this kind of situation, this kind of a very high plaque burden, and especially it's eccentric, it's highly likely to cause the stent expansion, resulted in the ovate shape, which we do not want to see. So maybe we need to continue this pullback, yes, to see the proximal and ostium of the RCA. We can see here is some composite fibrotic plaque, maybe a little bit calcification on the superficial, intima. Maybe I think that's more maybe using an NSE or an NC balloon to make further dilation of this part.
Oh,
Otherwise, I worry about the stent expansion of this site.
we'll choose a NC balloon, and the size will be bigger than the cutting balloon
Okay.
to modify the lesion again.
So for this case, that we noticed Professor Gong choose the antegrade approach first, because this is occluded segment is at the proximal part of the RCA, so favors for the antegrade approach. And also the occluded segment doesn't seem to be very long due to the bilateral angiography. However, I think that potential, backup plan should be considered for this patient. So, Professor Gong, if the antegrade doesn't work so well, what's your backup plan? Other strategies for this patient. Do you consider ADR for this one?
Of course, if the initial line entering the subintimal space, next we will consider the parallel wiring or the slingery-based ADR technique. And if all this fail, we will transfer to the retrograde approach
Okay.
according to the segment criteria.
Okay, thank you. So why do we put a guiding catheter for the left coronary artery? One thing is that we use it as an bilateral, angiography tool, so that we can confirm the antegrade wire position, just like Professor Gong just did. So that you can see whenever a CTO wire passes through the CTO segment, it's hard to identify the distal part, whether it's in the true lumen or not. Yes, you can perform tip injection. However, we need to emphasize that this kind of procedure is of a high potential risk to cause, for example, hematoma dissection if the distal wire is not in the true lumen. So the bilateral angiography using the contralateral angiography is relatively safe. So we are keeping the BL guiding catheter in the left coronary artery as an how to say that help to identify the distal wear position. And the next thing is that keeping an wire in the LED is also very helpful because you need to make some preparation in the potential some risk. For example, the left coronary artery guiding catheter cause some trouble, for example, dissection, hematoma. So keeping an aware in the LED helps maintain the coaxial position of the getting catheter, make it stable, and also avoids the further potential risk factors. We notice that for the antegrade approach, we first use an filter family wire because a filter family wire is an hydrophilic coated and it's a composite core wire with a very good maneuverability and also torque responsibility. And also it's a very good responsibility to help you to identify the plaque composition and also the response of the plaque. I think it's a good choice for us to make some introduction of the FFR. I think some advantage of this blood device need to be focused. One thing is that you can see it's a microcatheter based, and the diameter and also the size of this catheter is quite small. And our data for this microcatheter is that it's much smaller compared to the macrocatheter. So that you can see the microcatheter is so tiny, so we do not worry too much that the catheter is occupying the space and also the blocking the blood pressures from the proximal part, which means that this kind of devices is superior to that of the wire-based FFR, which means that it doesn't, influence the accuracy and also the final result of this measurement. And I noticed that there is a similar device in the US, which is performed by the Assist company. However, I need to emphasize that this device is superior by the diameter and also the size of the catheter to the other products currently on the market of this microcatheter-based FFR. And also you may notice on the tip of this microcatheter there is a pressure sensitive devices to measure the pressure of the distal coronary artery and compared to the aortic pressure. So this is how do we perform this one, and it's a quick exchange system, that which means that you can put it on a working horsepower with a relatively very rapid sending through the devices, and you can make some multiple measurements. For example, you can measure the diagonal, measure the LED, measure the RCA post stenting, because we know recently that the manuscript indicated that after stenting, the FFR value should be over 0.9%, 0.9, to make some promise to the prognosis of the patient. So I believe that this microcatheter-based FFR system is of a great convenience to the clinical usage, because with this one on the working houseware, you can measure almost all the vessels that you can wear with a working houseware. So this is of great clinical convenience for the clinical usage. This is our 100% domestic software. This is after the NC balloon dilation, right?
Yeah.
First thing is that we use a cutting balloon, to make some controlled, very tiny dissection for the intima. And then we use the NC balloon to dilate the plaque burden to help the intima to make some controlled dissection. This makes sense, I think.
Now
So,
we will uh, uh, implant the stent.
mhm. So it's a 3.5 by
By 13.3.
okay. So here is another question. What's a routine wear escalation plan? I think that the first choice is always, majority of the time is always a fielder family wear. And then we may make some wear escalation according to the situation of the plaque. If it's relatively very hard, very dense with calcification, so maybe an Gaia family wear is a good choice. And then, if the penetration with the Gaia family doesn't work very well, maybe potential the
Okay.
the CP12 and other very stiff wear is a good choice.
Contrast.
However,
Okay.
sometimes that the wear
Okay.
escalation is one choice. Sometimes we need to switch to relatively softer and relatively more safe strategies. For example, the
Okay.
fielder XTR, etc. But it's according to the situation. Sometimes when it's very torturous with how to say potential the macro channels, so maybe relatively softer, good maneuverability and good response wear is a good choice. So we can see that Professor Gong has implanted the first stent, and according to the angio, it seems to be well expanded. And according to the consensus of the European guidelines, that stent expansion should avoid in the landing as the relatively not so normal segment, which means the plaque burden is over 50%. However, from the IVS imaging, we notice that there is a relatively normal segment of the proximal landing zone, so we can avoid to land on the plaque burden with over 50%. And also, we notice that there are several risk factors of this patient. For example, the hypertension, smoking. So good medication is a relatively very important basic for this patient. Okay, now we are making a pullback to check the stent situation of the RCA. Okay, I think the proximal landing zone is perfect. There is no dissection, no hematoma. Again, the proximal plaque doesn't seem to be any change. For the distal part, my suggestion is that maybe 3.5, yes, 3.5 again, NC balloon, maybe at a relatively larger atmosphere, higher pressure. The mid part is 3.7, so maybe 18 something for the mid distal part of the stent. Later, we will use our domestic catheter-based FFR software to measure the FFR for the diagonal branch. And this software is 100% made in China. It's developed by the Beijing company. We can see again after NC balloon dilation, we can see the stent is well expanded. It's all attached to the vessel wall without any malposition, without dissection. And also here seems to be the most severe stenosis part with eccentric plaque burden. We notice that after cutting balloon combined with NC balloon modification, the plaque burden has been well controlled and dissected. So we can see the stent is a perfect, circle. It's instead of an oval shape, just like I introduced. Maybe we continue this pullback to see the, yes, proximal part of the RCA. Okay. I think the whole stent is well expanded. The MSA is over 8.6. I think this is enough.
Okay, I will to check the off term of the RCA.
Okay. From this one, doesn't seems to be any, severe damage to the ostium of the RCA.
Okay.
Okay, perfect, I think. And also the distal perfusion is much better compared to the original. So I think that this patient is going to, symptoms is relief very much because we can see the perfusion or the RCA is a large vessel. It's a red dominant. Okay, perfect. I think this is a good chance because we have the IVUS on the table for the RCA recanalization. And we are going to perform the function test FFR, microcatheter-based FFR for the diagonal. So later we are first try to use the IVI system to measure the minimum lumen area of the diagonal branch, and then we use FFR to test. So this is a good comparison. What's the result of the IVI system minimum lumen area? Cutoff value to predict whether there is ischemia or not. And on the other hand is function test, the physiology evaluation for the diagonal branch. So I think that this is an internal question, whether to use the IVUS or the FFR to identify or to evaluate the intermediate lesion, whether it's need to be treated or not. So I think this is a good chance for us to have a direct view, how to perform it and how to treat it. And finally, to answer the initial question, for the intermediate lesion, which kind of devices should be used? What's the best choice? Okay, we are performing the equalization. Okay, you can see the microcatheter was sent through the stenosis very smoothly to the distal part of the diagonal branch. So this is one of the advantage of the microcatheter-based FFR, I think, because you can use it on a working horse wire. So you can do it frequently, and also do not worry that the FFR wire is passing through with a difficulty.
Okay.
I think that the resting PTPA is 0.93, so it's hard to say. We know that the cutoff value for the resting PTPA is 0.92, so we can tell this is a very focal, very short, stenosis at the diagonal ostium. What the FFR value is going to be. Okay, I think that there is no drift. Okay, almost 1.0.
Very good.
Okay.
There is no drift. 1 is 0.85.
Let me check again for the
0.85.
Yes, I think that the two maritimes the same value. The first time is 0.5. The second is also 0.5.
Okay.
0.85. 0.85. It's very stable and there is no drift for the 2 times measurement. I think that this one meets the cutoff value for the IOS image also because we notice the MLA is 3.0
Yeah.
and also the lesion length is relatively short.
And for the lesion, we should choose MDT.
We defer this
Uh,
focal lesion.
yes.
I think this is a good demonstration because from the angiography, I think the majority of the operator will worry whether it's a positive lesion and whether need to perform the very complex stress release or not. However, for the FFR value, we can see that, yes, it's benign. We do not need to perform the revascularization. I think this is a good demonstration for this one.
Okay. And the last step, we will perform IBAS imaging for the previous denting the LED.
Okay.
Then we will finish the procedure.
Okay. Although from the angiography, it seems to be very focal severe stenosis, but we have just performed the FFR, and
Spasm.
also the eye
The
was
optum is spasm.
indicated that
To give
the
me,
minimum
yeah.
lumen area is over 3 millimeters square, so we do not worry too much about the diagonal. However, we emphasize that a good medical therapy for this patient is a base, and so we need to make some well-controlled blood pressure, the lipid, and also quick smoking to suggest the patient. And after some vasodilator, we are going to repeat the angiography to see the situation of the whole vessel from the left coronary artery.
Okay. Okay.
Okay, it's a very big diagonal
Still
branch.
spasm.
I think it's got much better, and I think I perform FFR. It's a TIMI3 flow. We do not worry too much, I think.